On to our speakers. So again, this session is about using partnerships and peer-led approaches to tackle health inequalities. We're going to be hearing from two expert organisations, Groundwell and Turning Point. And we're going to be learning from their experience of tackling health inequalities both locally and nationally. And hearing about the influences and the challenges and the impact of the kind of partnership work that they've been engaged in. Our speakers, they'll all introduce themselves as they come up, so I'll just be very brief now, just to say from Turning Point, we've got Amy Stevenson, Michael Huck and Leon Nicholson. And from Groundswell, we have Joe Brown and Martin Murphy. And I think we're also going to be joined for the Q&A, which we'll handle at the end by Jerry Rolfe, also from Groundswell. Now, these are people with a wealth of experience and expertise, so have your notepads ready, because there's going to be lots of learning coming out of this session. And I'll hand over now to the speakers, and I think, Joe and Amy, we're starting with you.
Hi, yeah, Joe, I wonder whether you want to start, and I'm just not sure whether anyone's got the PowerPoint. I don't know whether Laura was going to pop that up for us.
Yes, it's coming. Give me one
second.
Super,
thank you. I guess whilst we're doing that, I'll just introduce myself. I'm going to be doing the intro for us and kind of close with some of the conclusions that we've come to through pulling this presentation together. So in the spirit of partnership, we've very much done this collaboratively. So this is a joint effort. So I'm Amy Stevenson. I'm Head of Health and Wellbeing at Turning Point. And Joe, if you want to introduce yourself and Groundswell, and then we can kind of kick off into the slides, I think.
Great, thanks, Amy. Hi everyone, so I'm Jo Brown, I'm Research Manager at Groundwell. For those who don't know, Groundwell is a homeless health charity. So we're primarily based in London, but I'm going to be talking about some of our kind of national partnership work today. And the kind of rationale, everything that we do, as we've already kind of talked about in the earlier session, if you're here, is around that participation and ensuring people with direct experience of homelessness are involved in the solutions to tackling homelessness themselves.
Thanks, Joe. So for those who have not heard of Turning Point as well, we are, hang on, I'm just waiting for the slides. It's fine. So we're a national social enterprise, and we've existed for over 50 years. We currently work in over 300 locations across England. So we're a national organisation, and we support over 100,000 people by providing a range of health and social care services. So that includes drug and alcohol services, mental health support, support for people around offending behaviour and employment issues, and also we support people with a learning disability. And I think we've kind of gone to the bit already around encouraging you all to introduce yourselves in the chat. So we're looking forward to seeing who else is going to be joining on this session as well. So the aims for our session, if we can just move through to that slide, thank you, is so what we wanted to do with this session is to share our experience. You'll all have yours, and we're looking forward to the questions and hearing some of that as well, but to share our learning on how health inequalities can be tackled through ways of working which are driven by partnerships and peer-led approaches. Some of you who have been on the event today will have heard a bit around these themes already, which is great. We also wanted to demonstrate and contribute to the conversation around what voluntary, community and social enterprise sector can do to tackle health inequalities. So a bit of background before we move on to the examples that we've got today. So when Groundswell and Turning Point came together to plan this session, we talked about the fact that many people we work with and support are already, we know, are more likely to have poorer health outcomes in certain areas, experience multiple inequalities, and problems in accessing services, full stop, with poverty being one of the big causes behind that. Now, although we could have talked all day about the different and practical approaches that each of us use, we decided to focus on the cross-cutting themes of partnerships and peer-led approaches, because that's something that aligns us as organisations, the way that we work. But we also strongly believe that there are mechanisms to help break down power imbalances and enable a shared approach to creating that fairer society that we've been talking about today. So we're going to demonstrate our practical experience of utilising partnerships and peer-led approaches through two examples. So the first is a local example of how Turning Point and Groundswell have worked together in partnership in London. And the Turning Point service there is a drug and alcohol service. So I'll hand over in a moment to Michael, and Martin and Leon are also going to contribute to telling us about that local example. But we also wanted to give a bit of a national kind of lens to this as well. So Joe is then going to share a national example with us, which comes specifically from Groundswell. So I'll now hand over to Michael, who's going to kick off sharing our first example.
Thank you, Amy. Thank you, everybody, for joining us this afternoon. Also wanted to thank the previous panelists and the participants from this earlier afternoon. It's really good to be part of this. So I just wanted to talk briefly, Joe, if you could go back to the previous slide, talk briefly about the origins of the partnership, I suppose, between the Drug and Alcohol Wellbeing Service and Groundswell. It's always really interesting to be referred to as an expert. I am of the strong belief that the peer mentors in the service in which I work are the experts in our local community. But before I go on to talk a bit more about the values that underpin the work that we've done, I wanted to set the scene, really, because I think that's important. In the earlier session, there was some discussion and conversation about the role of local authorities and government in fostering an environment, I suppose, where peer-led organisations and approaches can flourish. And I wanted to start with that, really, just to talk about the incredible support that we've had from our commissioners and councils and local authorities in central West London. You may not pick up from the accent, but I am from the West Country, and I moved to London about 6 years ago now to take up the role of peer mentor and volunteer manager at the Drug and Alcohol Wellbeing Service. And my first day, and to illustrate the commitment from the commissioners, my first day was a peer-led conference that was held at the Paddington Arts Centre, and that was organised by the commissioners and involved support from all of the local providers in the boroughs who currently were offering peer support programs and peer mentoring training as part of their offer to the local community. So that was my first day, and to have the opportunity to hear our Chief Commissioner talk about the value of peer support and what it means for people in the local community and how it can support people to achieve better outcomes. And those outcomes are around health, are around poverty. And I think Amy will probably talk a bit later on about some of the statistics from Turning Point in terms of people who have gone on from peer mentoring into paid employment. And we're really proud to be able to support that. So that's just a brief example of the support that we had from the commissioning team, and also regular commissioner-led quarterly meetings for peer support organisations in the 3 boroughs demonstrated to me when I joined the team in London that the council take peer support services and peer mentoring incredibly seriously and see the value in that. So that was my first day, and it's interesting how Groundswell and our service began to work together, because I was introduced to Martin, who's a fellow panelist in today's presentation, through a mutual volunteer who was, as well as peer mentoring at our service, also volunteering and supporting Groundswell, and had been for a number of years. So that's how I think my memory serves how Martin and I first met, if you like, and I think what's really helped us, I think, is, and I know that Martin's going to go on and talk a bit more about the relationships and the values. I think what's really helped us is our shared principles and values around peer mentoring, peer support, and peer-led services. And so we, I guess, fairly quickly decided that it would be useful, I think, to bring peer-led organisations in the 3 boroughs together to help us to understand what each of our services offer and how we can work together to support local people in our boroughs. So we did establish a peer-led networking meeting, and just in terms of some of the examples of how we then began to work together, mutual training. So a really important role for our team to provide some specialist training to the volunteers at Groundswell on the drug and alcohol wellbeing service, and also for Groundswell to contribute to training and supporting our peer mentors in understanding what Groundswell can offer. So being able to support service users to attend health appointments and other really important appointments where they need to be escorted. And I'm mindful of the time. 5 minutes goes very quickly, but I wanted to just close with, I guess I would say the pandemic has challenged us to think really differently about peer-led services in our boroughs, and how we can continue to recruit and train peer mentors to be able to support people in the community. And we're really proud to be part of a group of organisations who are going to be supporting a day of action to vaccinate people who are clinically vulnerable against COVID-19. So that's a piece of work that we're working alongside Groundswell with in central London.
Okay, thanks, Michael. I think we're going to hear from Martin now. Martin, are you with us? If not,
sorry, as usual, I didn't unmute myself. It's a regular habit. Apologies for that. So just following on from what Michael has said, so I'm Martin Murphy. I've been working with Groundswell now for about 10 years. It's a much smaller organisation when I started, so I've seen a lot of changes, and actually a lot more kind of peer work, and slowly seeing it being better recognised. A lot of the work Michael and I were doing at the beginning of our collaboration was in many ways about focusing on relationship development. Michael and I spent a lot of time talking about our shared values and importantly the importance of building relationships between our kind of respective peer groups, supporting their development by building on their existing peer relationships. So, they have there's a peer network within Turning Point, but let's match that up with the peer network within Groundswell, and get some shared learning going on and build relationships, to ultimately help to better engage our respective client groups. So we both kind of recognise the value of the relationships that peers could build with those people who are using our respective services, and the crossover between those two sets of experiences. It's a dynamic of engagement, another kind of tool in our box, really, another method of engaging people that use our services in becoming perhaps a little bit more proactive in their own recovery. At its best, the service user peer relationship can help the service users see a way out of their current predicament that perhaps a traditional service user professional relationship cannot. almost a recognition of self. This person was where I am now at one point, but look at them now. Perhaps there's a chance that, you know, things can improve for me. And that dynamic takes place in that relationship, whether spoken or unspoken, I think it's fair to say. So it's a clear logic to me, but that doesn't mean championing peer work or you know, trying to drive peer work and collaborating on it between two organisations with different agendas is easy. You know, it's not. We're drawn into other elements of our work, and this has certainly happened by the priorities of, you know, the different priorities of the organisations we work for. But I think what's really interesting is that I think our beliefs around the effectiveness of peer interventions kind of always draw us back at some point. You know, well demonstrated really by current events. Groundswell were asked to help with the rollout of the COVID-19 vaccinations to the homeless population by providing volunteers and staff to work with the roving teams of vaccinators. I mean, we don't have the capacity to help in all areas. We couldn't cover all sites. So the first person who popped into my head was Michael, and you know, the response really was kind of just as I expected. It would be a genuine willingness to help and a kind of swift yes to the request. In fact, we'll be working together tomorrow, I think, as Michael's already mentioned, on those vaccinations in Westminster. I think it's also important to look at the fact that, you know, by all accounts, 60% of Turning Point staff and probably the same or more of Groundswell staff team have lived experience of substance use and or homelessness, and are in recovery, whether that be lifestyle or from drug and alcohol. I mean, both of us grow in organisations, which in itself is a powerful testimony to the work that we do, the approach we take, and you know, above all, the effectiveness of the work that we do. It works, and that's the important thing to take from this, really. So as organisations, we have a lot in common, different specialities, different skill sets perhaps, but a similar approach and a similar recognition of the kind of passion and dedication the recovery experience brings to our workforce. We can and should do more, you know, in my opinion. Our collaboration is good for our staff teams and ultimately good for those people who have need of the services that we provide. I mean, in that spirit, I'm going to hand over to Leon, who's going to say a few words about a more recent collaboration between our two organisations, the PI-MDT project in Westminster, a multidisciplinary team and collaboration between SLAM, psychological, the homeless health team, physical health, Turning Point, obviously substance use in this context anyway, and Groundswell with Advocacy. With a good portion of kind of lived experience thrown into the mix. I believe within that team that lived experience in the role of the advocate and complex care navigators has taken the peer experience to a little bit of another level within the field of health and social care. So I'll hand over to Leon to say a little bit more about that.
Thank you, Martin. Can we have the next slide, please? Okay, so I'm Leon. I'm a manager of the Westminster PI-MDT partnership team, Westminster, for Turning Point. I'll tell you a little bit about the project. It is a Public Health England funded project, and luckily it is in 6 local authorities, and Westminster was one of those local authorities that was selected to deliver the psychologically informed environments project, and it gave us a real opportunity to look at the individuals within the community with past experience of rough sleeping or current rough sleepers, any homelessness and revolving doors, the real marginalized individuals that, you know, they are barriers to engaging with frontline services. Generally, they normally engage, disengage, have challenging relationships with those professionals, and it prevented them from accessing services. And we decided, like all the local authorities that was awarded the project, it was originally done for 1 year. It's evaluated by Sheffield University, I believe. I might be incorrect to that, but I think it's Sheffield. So there's a continued evaluation. We've just had it extended for another year, and it's a real opportunity for the lessons learned through the past year to the forthcoming year to really give the support to those vulnerable people, adults, male, female, anybody that falls into a particular criteria. Now, the criteria for the PIMDT, which is mental health, physical health, substance misuse, and homelessness. If you can meet any of those criteria, then you can have access to our service. And the service is a partnership working with the local public health authority. So we have nurses involved on the team. We have 2 psychologists, turning point navigators, and we have a peer navigator, which is the real on the road, going out and meeting the client. So the real importance of allowing those navigators to engage the clients that we do, and it is highly successful over the past year. You know, the clients that we engage, it's really about the relationships that we build. We understand that they have challenges accessing services or maintaining engagement with those services to be able to access the correct support, the support that they need, not what we think the right support is, of what they actually need, and it's working with that individual. So it's a real good relationship building project. I say about the relationships are extremely important with the clients, you know, the real good quality relationships, listening, caring, being reliable, consistent, flexible. I mean, we can mention a lot of the key punch words that we do to build up the importance of the relationships with the client. But it's also the relationship in which we as partners work with the other professionals in that team to deliver the service and the support that is right for the client. And one of those is although lived experience is throughout our service, I think it's well over 60% of the people in our service have some form of lived experience. It is still a barrier because of the concept of the power imbalance. We're professional and it can form barriers. So there's a real emphasis of having that peer navigator that we have through Groundwell, which actually allows the client to have the engagement to feel they've got the engagement at an equal level, which then overcomes the barriers with engaging with our navigators for the substance misuse, the nurses that are on hand, and a psychologist. And doing partnership working is Groundwell working with the psychologists with the nursing to engage a client at the same time. So it brings down all the barriers that the client is facing and stops them. I think there's been, over the past, I think 5-10 years, a mass increase in the age of our homeless people, and with that comes physical health problems. And so we recognise there's a real importance of having those navigators that are able to provide the support for those clients to attend appointments, hospital appointments, support when they leave hospital, you know, just the daily talking to a client, to have that relationship. And it all stems back to the psychologically informed process. So, I mean, as most people know, what hopefully psychologically informed environment sounds is we try and create the environment around the client rather than the client fitting into our current environment in what professionals expect. So they go to one service, that environment engagement will be completely different. And again, they'd go to Turning Point and that would be completely different from the going to the GP. So what we try is that we all work together by weekly MDTs, multidisciplinary team meetings, to ensure that we're all communicating on the same page and able to communicate with the client so they're able to understand. And it's forming that relationships completely as a whole, including the peer navigators and the navigators for the substance misuse and the psychologists, is bringing all that together into one, as we can see on the slide, is important to ensuring that the clients that we engage with are able to access them services and continued support over time to access them services. So it's not just taking them to the GP and leaving them, we will continually follow their path to access any physical, mental health or substance misuse needs. And accommodation, I mustn't forget, Westminster Council have been very supportive in this. And they was very enthusiastic to bring our navigators and Groundwell on, but accommodation is highly important, so they've also played a big part in actually in the team in supporting us getting people accommodation, which is one thing we have noticed through doing these complex needs services is all the services need to be delivered simultaneously or very speedily together rather than disjointed and silo. So once we bring them all together, the outcomes appear to be a lot better so far.
Leon,
we wait for the evaluation.
I'm just going to, so I was just going to say, Leon, thank you very much for that. That's really, really helpful and kind of a view from the front line. I do want to, I'm conscious of time, so I want to bring Amy and Joe back in because I think they want to give a kind of an overview of the partnership approach as a whole, perhaps take it up to the national level. So Amy, Joe, could I hand back to you now?
Thanks, Miles. If I can have the next slide, that'd be great. Great. So we've talked a little bit about how Groundswell and Turning Point operationalise this peer-led approach at a local level. And one of the things that we really wanted to do at Groundswell and we've been thinking about is how we then make sure that we can share this learning. So we know that homeless health peer advocacy, we know that peer-led approaches are working in London. And we actually did an evaluation of that, our homeless health peer advocacy service. And in terms of how that impacts people's patient experience and outcomes, we found that there was a 68% reduction in missed outpatient appointments from this approach of having that peer advocate support you to access the health services and get your needs met. So we wanted to develop this approach. One of the things that we wanted to do, we didn't want to become, a national organisation. We wanted to maintain that locality, but actually bring on board partners who were already set up locally and share that learning so that we could scale up some of the work that we did. So that's kind of where the Health Now partnership came from. And the Health Now partnership is something that I wanted to talk about today because actually at its core is the element of partnerships, but also peer-led approaches to tackling homeless health inequalities. And that's not just about, we've talked a little bit before about consultation versus co-production. The point of Health Now is making sure that there's this meaningful approaches to engaging with people. It's not about, giving people a voice, it's about giving people a platform to have their voices heard. And that's how the Health Now partnership works. So we're working in partnership with Prices and Shelter on this project in 3 partner cities. So we wanted to work out if this approach would work in different cities. And you'll also see on that map there as well, there's some other areas that we've started to scale up to the homeless health peer advocacy. So we've got pilots in Dublin, with DePaul, we've got places like Cornwall, and then we have our 3 partner cities, Newcastle, Greater Manchester and Birmingham, where we're partnering with Crisis and Shelter. And we were really lucky to get some lottery funding to carry out this work. And that's where the Health Now campaign emerged. So can I have the next slide, please? So the theme of today, again, it's all around how we can tackle these health inequalities. Obviously for Groundswell specifically, this is focusing on homeless health inequalities, but a lot of the approaches that we use and a lot of the kind of insights that we gather would reflect kind of any inclusion health groups. So the Health Now vision is all about this inclusive health system where everyone has equal access to the healthcare they need. So one element of that is, as we've discussed, is bringing some of them approaches that we use in London, these peer-led approaches to supporting people, but also we want to have a real understanding of what's happening locally and what the key barriers are for people in them 3 partner cities, and find out how we can then improve things and develop local action plans. So the partnership, the kind of approach that we lead on, we have the homeless health peer advocacy set up. We also have peer-led research set up in each area. So we train a group of people with experience of homelessness to not just consult on the research, but actually design it, deliver it, and come together to analyse the research that we're doing and input into the reporting and how that's then disseminated. From that all feeds into a local alliance. So one of the things that we think is really important is getting the right people sat around the table. So in each of them areas, we've got a local alliance, which has people from housing, people from health. We know that often housing and health don't often come together as much as they could, and also people with direct experience. So then people can use that as a mechanism to hold people to account and hold decision makers to account. And we're able to do that through that partnership approach, where we know that Crisis and Shelter already have them relationships and already have peers who can be really informed and really involved in that local delivery of that approach. And then again, that comes to a kind of national level. So I'm going to move on to the next slide and I'll talk just a little bit around some of the impact. So as we said, it's all about this creating change. It's a 4-year project and we are in the 2nd year currently. But it's about bringing together them alliances, so making sure you have the right people sat around the table and making sure that you have a platform for peers to hold decision makers to account. So we've already set up them alliances in them areas. We've conducted the first set of peer-led research on local barriers. Obviously, we had to change slightly our approach because of COVID, so we've had to be paused slightly with that and adapt to it. And all of that's going to feed into this action plan at a local level, which then can be utilised for the local peers to then kind of say to the Alliance, what are we going to do about this? Who's accountable for this? What are the tangible kind of goals that we want to achieve locally to eradicate homeless health inequalities? Can I have the next slide, please? As I say, that's kind of really kind of local level focus, but what it gives us the opportunity to do as well is to bring everyone together as a national network of peers. So we regularly kind of have a session where we bring together people with direct experience who are volunteering peer roles across them 3 areas, but also across the different areas we operate, and bringing on board other organisations, so Fulfilling Lives, Pathway, so anyone who works with or kind of volunteers in a peer role can come together and learn and share from that. We can have the research that's conducted nationally, but also look at the different 3 areas and think about actually what are some of the local issues, but what are some of them things that need to be raised nationally, and how we can then make sure that we're getting the right people again sat around the table to hold them decision makers to account at a national level. May I have the next slide, please? So I guess what I really wanted to talk about is about how, this whole session's been around how we would advocate for partnership working and also peer-led approaches. And I think the impact that has, it avoids duplication. A lot of people are within the sector doing some really great work, and it makes sense to link up that work and make sure that we're not kind of stepping on each other's toes trying to do something when we all have the same ethos. It means that things that are peer-led are a lot more kind of eliminating them power dynamics, but also end up with more tangible and appropriate solutions, because it's people who are experts at knowing the situation and knowing what would work and what wouldn't. So this is kind of just a breakdown here of how our approach worked. So we kind of set up them alliances so they could hold decision makers to account, connect them peers together. And one of the things that we think is, you know, if you invest in people, if you give a lot, you get a lot back. And I know we've talked about things around incentives and kind of volunteering, and I'm happy to chat further about that. But a lot of the people who volunteer with us and give their time, it's really about ensuring that they get their voices heard, and they want to give back in some ways, because they might have been supported through a charity that's helped, or it might be that they want to make sure that they can advocate for people who are in a position that they once were. And really just thinking about how we work together. And I think today it's a great opportunity to think about how we work together within the voluntary sector, to make sure that we're kind of promoting these approaches that involve people with experience of whatever marginalised group or issue that we're thinking about, but also how we work together as partners. I think one of the things that has really kind of helped, and we've had a lot of impact with the work that we've delivered during the COVID-19 pandemic. And I think that that's because we already had this kind of these partners and these peer-led approaches set up so we could mobilise them as a mechanism to kind of influence system change. So making sure that their voices were then fed directly into NHSE when they're talking about you know, decisions around the response to COVID. So having them mechanisms in place where you have everyone, homeless, health, and people with experience, really means that that's a vehicle for being able to do system change, not just at a local level, but at a national level as well. So I'm going to hand back over to Amy, because I'm conscious that we've got a really short time slot, but really happy to talk more about that in the Q&A.
Thanks, Joan. If we can just move on to the last slide, please, that would be great. What I just wanted to do was kind of round up with a number of conclusions that we came to ourselves as we were kind of pulling this presentation together and reflecting ourselves on our own partnership and peer-led approaches. So the first one being around that reality that we can't do everything ourselves. So we can't ignore the fact that the causes of health inequalities are broad and many are systemic across our society. So we can't do everything on our own, but we have a role to play as organisations, as networks. We can influence, and especially if we work together. So it means learning from each other, with each other, understanding the different skills, expertise and ways of working that we all bring, be that on a local or a national scale, as hopefully we've demonstrated today. We need to think broad, so understand the health inequalities that exist for the people and the individuals that we support, be that as a result of specific vulnerabilities, be it about geography or around the social determinants of health that we've heard a lot about today. So housing, wealth, employment, poverty. So really kind of thinking of people as a whole, of all of those different factors that contributes particularly to health inequalities. Power of the peers, hopefully we've demonstrated this already, but when it comes to understanding the role we each play in reducing health inequalities, thinking about what we can do, we have to be guided by and work collaboratively with people who have a lived experience. Relationships, we reflected on, as Martin brought in, that pulling from our experiences together on how important human relationships are in building partnerships and maintaining partnerships with each other, and also with people with lived experience, and that kind of links really to the final point, because I think again when we were reflecting, and some of the examples we've shown have linked to that kind of organic approach that you can take around working and kind of developing through those relationships versus those formal approaches. And I think what we've tried to demonstrate is how some of those organic approaches of working together that we experienced in London actually have led to some of those more formal approaches of working in that multidisciplinary way that Leon described. So, and with that, talking about the reality of trial and error, we don't always get it right. So thanks so much for everyone who's shared. Just before we go on to the to kind of hearing your voices, and you might have some conclusions of your own from some of what we've shared. Martin highlighted the fact that Turning Point and Groundswell, many people who work for us identify as having a lived experience. And Jerry kindly agreed to join our panel today, so she's joining our conversation to bring her rich experience as someone with a lived experience, but also as someone who joined and trained as a volunteer before moving into employment with Groundswell. And now she sits on the board of trustees at Groundswell. So thanks so much to Jerry for joining us at this point and being able to bring your experience alongside ours.
Thank you.
Sorry, go ahead, Jerry. Go ahead.
All I'm going to say is the one great word there that everybody needs to remember is peer. Because without peer, there'd be no Groundswell. Groundswell survives because we do peer work. Our experience is endless. It's so necessary to use our experience to help our homeless client. Trust when you're homeless is something so hard to give to anybody, because you've been let down so many times. I know, being homeless myself for 5 years, you just didn't believe what people said. When I became a peer and I realised that the power that I had to help people who were in the same situation that I had been, it was, I don't know, it was mind-blowing. I suddenly realised that everything that I thought I was ashamed of, that I was disgraced and I shouldn't talk about, were the things that I needed to talk about to help people, to actually say to them, look, I understand, I've been there, I know how it is, I know how hard it is, but you can get through it. And with Groundswell, with any of the peers, they're there to help assist you and guide you. We're the buffer. You've got the professional this side and you've got the client this side. Groundswell acts as the buffer. We take sometimes all the blows that the consultants give and ease them out and give them to our clients so they can understand what actually is going on with their treatment. Back in the day, and I hope to God it's different now, some of the consultants were so up themselves, that's the only way I can put it, is they really didn't have time for homeless people. They thought they were third-class citizens. Well, they weren't when I was around, believe me. I would tell the consultant exactly what I thought of them, and that they should respect the person that's there asking for help. Believe me, the last place somebody wants to be who's homeless and got a lot more important things to do is to look after their health. They are very busy people. We have people to meet. We have checks to pick up. We have off licenses to go to. We have a dealer that we need to go to. Believe me, going to a health appointment is the last thing on their list. That's why peers are important. That's why you need peer support, because we can help them. We'll take them for a coffee. We'll buy them a sandwich, something that they don't often do, because the money in their pocket is used for other things that are important to them. And that is their addiction. And no matter what you try and do, addiction is something that has to be worked through with professionals, and you want to be able to do it. But people who are homeless probably are not at that stage. I know I wasn't. And I have to say, I'm an ex-Turning Point client. Without Turning Point, I probably wouldn't be here today. So Turning Point and Groundswell saved my life. Homeless. I mean, that's inequality straight away. You only have to say homeless and people just look at you as if you're dirt. You know, and by the grace of God, I now have my own home. But being homeless for 5 years on the street is so hard and degrading, and you lose everything. Just not your belongings, you lose your respect to yourself. You yourself think you're nothing. So what chance have you got if you think you're that way, that anybody else is what they're going to think of you? So I believe that with Groundswell, by empowering our clients, showing them, helping them, lending the hand, allowing them to go forward with you, not only empowers the client, but it empowers the peer. And the peer and the client's work is so important. Now, I could talk about this for hours and hours and hours. I retired from Groundswell last year after 10 years. I couldn't cope. I came back a month later. I'm now a volunteer, not only a trustee, but a volunteer, because I really believe what we do helps. and I wouldn't be here today if I didn't believe the power of the peer. I'll say it again, the power of a peer. You can't do without them. Thank you very much.
Thank you, Jerry. That's amazing, and yeah, the power of the peer, and I think also the power of the testimony from a person who's been there and lived it and knows it in a way that the professionals and policymakers never will. And I think what's been fantastic about this session is kind of hearing all of that, really. You know, the lived experience, the kind of front line, for want of a better word, experience of kind of delivering the care and the service, and then also the kind of higher level thinking about what the partnership is about and how it can be made to work. And I know there's more as well that you could have put in. Some of you probably, you're haggling with the funders and the policymakers and all of that. So
I got money for Groundswell, left, right and centre. Go and tell them your story, and if they didn't give us money, I'll just cry. Because we need the funders, we need to extend what we're doing. You know, money in the pocket is great because that allows us to expand what we're doing, to work with more people. So we have to be nice to funders. And thank you to all the commissioners if you're out there listening. We appreciate it. Humbly thank you. So just keep giving us money, please. There you go. Bit more begging, I can do that.
I'd like to just bring in, because people have been putting questions in the Q&A, but also in the chat that I've been keeping an eye on. There's various sorts of comments and things in there that I'd like to pick out in the time we've got left. We've got just under about 10 minutes left before we have to wind up the session and close the conference for this first day of it. So just a couple of things that I spotted there, which I'd like to put to all of you. Don't really mind who picks it up. Somebody actually, there was something that came in, actually, I think it was the end of the last session actually, but it feeds beautifully into this one. Somebody was asking a question about where are the kind of sustainable solutions, was the word they were using, to all of this. So questions about housing and homelessness, poverty, exclusion, and all of that, and I guess including health issues, physical and mental health issues, and so on. So that was quite a big picture question about kind of strategy long term. When will this all end, or is it just destined to kind of go on as a struggle forever? But also somebody in the chat then put in something that might be more about kind of tactics in the meantime, which was about looking for ways to remove the obstacles that are in the way, I think, in the here and now. I'm hoping that was what the person was meaning. So to throw that over to any of you who wants to have a go at that, there's a kind of long-term strategic question about how do we solve some of these really deep and difficult problems and inequalities, but also in the meantime, I suppose, what are the kind of tactics and how do you remove the immediate obstacles that are in the way? Anyone want to have a go at that?
Just a quick comment, Miles. I think, you know, sometimes the bigger picture is a distraction from what needs to be done on the ground, you know. There are people that do that, but we have to make sure we have what's in front of us. We'd all like the political situation possibly to be different, but we've got what's in front of us. You know, we've got people who need our help and support, and that's what we deal with on a day-to-day basis. And you know, we need to make sure we deliver that, whatever the circumstances are. We have more people probably than we would like, but that's even more of an incentive for us to focus on what's in front of us and the people who need our support.
I just add to that as well, I guess. So part of, you know, the especially models like homeless health peer advocacy, it's about not just supporting people, but also giving them the tools and resources to be able to advocate for themselves going forward. So I think in terms of like people feeling the access to support to access health services, having that support where you're not just, you know, you're not cradling people, but you're actually supporting them in a way so that they understand their rights, they understand their needs, and they can then advocate for themselves and others. I guess in terms of on a broader scale, I think that's where, you know, we need to have them services in place based on the world that we live in at the minute. But ideally, you know, a lot of the research and working together to understand what the barriers are and create kind of really tangible solutions, that's really about trying to break down them barriers. And and break down them barriers in a way that we're aware of the current situation. How can we change that? But in the meantime, also having that support for people. So I think it's a two-pronged approach, I guess. I don't know if Amy or...
I guess totally agree with what you've both just talked about. I guess what went through my mind, which kind of links to that, as in terms of how, and it was touched on earlier, I can't remember whether it was in the last session or this morning, but that idea around people not always connecting what's going on around them with health. I just wanted to kind of bring that back a little bit, because I just think that's something that's really important. And I think we do, in many ways, we work really holistically with people. So yeah, are thinking and helping people to think about what's going on in their lives, how it's affecting them, and really important that we are led by the individuals that we are funded to support. But I think that's equally as important for our colleagues as well, and thinking just so we all have that really clear understanding of what health inequalities are, how they affect ourselves as well as the people that we support, and kind of what are those factors that influence on health. I think one of the things that we often try and focus on at Turning Point across all of our services is not just around the kind of reason that someone might have accessed our service, but what can we do to initiate that longer term change for individuals when they're in front of us. And that's building on what we've talked about around how we enable and as Joe said, kind of provide tools and resources for people to do that for themselves. It's really important that that staff understand that as well. So I just wanted to come back to that bit around us really understanding what impacts on our health and the many different factors that are brought into that.
I think also, if I might add something, that in the earlier session there was a really important conversation about co-production, and I think that is an approach that can help overcome some of the barriers that we experience, that people experience. And I think locally we I think in terms of the principles that guide that, people were talking about, sometimes with co-production, a lot of really great work is done, and then those who are the decision makers perhaps don't take into account the work that's been done. And we've recently set up a project to look at what have we been doing over the course of the pandemic that's been working for the people that we support. What have we been doing that perhaps we should do more of or less of? From that, there were some themes identified, and we locally set up a co-production panel, and I think we were guided by some of the principles which one of the speakers in the first session talked about in terms of developing our co-production project. So really important for us that it's not just service users that we train and upskill to be able to play a meaningful part in co-production, but that we also train the staff and the management, and including our operations team. They're all part of the co-production panel, and they've all been trained together. And so any decisions that need to be made, we have the right people in the panel, in the room, to be able to make those decisions. So that's really good.
Okay, that's great, thank you. I'm going to throw in one last quick question, because we are running out of time now. But somebody has asked a question about kind of terminology. If we're talking about peer-led approaches, is there a difference between peer-led or peer-managed or peer-run? I know we have these kind of debates and talking about kind of patient and public involvement. People say, is it involvement, is it participation, is it engagement, what is it? So a peer-led, peer-managed, peer-run, is it all more or less the same thing, or are there important differences? I need a quick answer from someone.
Okay, I think, Miles, in my view, I would say yes. Peer-led, peer-managed are the same thing, certainly from my perspective in our service.
Anyone else want a quick go at that?
I just add that, yeah, I speak about peer-led approaches, but one of the things that I think is really important is that was decided with conversations with peers about how, they think that they should be, referred to, so how they'd like to be referred to. So, you've got different labels around experts by experience, or, someone with lived experience. Actually, on the project or whatever you're doing, ask the people, don't ask people like me, ask people like Jerry, to
peer
say
empowerment. That's all I'm going to say. Peer empowerment.
Yeah, and I think
that's
no one size fits all. It's just about making sure that it works for, you know, whoever that you're doing the co-production with.
I will also add that I've not heard of the term peer managed before. We certainly don't use that term. Certainly in our service, peer led is the I guess how we'd refer to something that a peer mentor is leading on, whether that's a peer led support group or something else. That's the term that we would normally use.
Brilliant, thank you very much.
It's degrees as well, isn't it? Sorry.
Okay, I need to wind this up now because we're kind of out of time. I would like to finish by saying thank you for everybody who's come in as sort of participants and observers on this. Really nice to have you here and to see all the comments coming up in the chat. I'd like to say thank you to our great panel of speakers here. There's too many of you to name individually, but thank you to Groundswell and Turning Point for sharing your learning on all of this. I'd like to also thank National Voices, of course, for hosting the whole thing with support from Health Foundation and PPL. And just to finish by reminding you that this is just day one of what's a 4-day event running through the whole of March. Again, those subsequent dates, that's the 9th of March, 16th of March, 23rd of March. Get details on all of that from the National Voices website. It's a really packed program and some really good stuff coming up. So do go and check out those details and tune into future sessions. And I think that's it for now. Thank you and goodbye.